Just really to go on about what we did. So obviously we are quite a large site, and we're also a multi-site. That means that we have other settings that feed into us, various, I think there's about 3 or 4 sites that can feed into us. So not all of the time were the screening and the way that these patients were passed across or came across our flagging system, if you will, was accurate. So what we started to do is we had a new PAC system implemented at the Trust. And from that, we were able to actually start flagging and creating a daily search, which means that we were easily able to go into the X-rays. One of the drawbacks that we have found so far is that the X-ray system we do use at the moment, unfortunately, doesn't come with a proximal humerus flag. So we have to identify two avenues, if you will. I look at what comes under the shoulders, and also I have to look into the arm X-rays. Now what I do on a daily basis is I start to literally go through the X-rays from the previous day. It is a bit time consuming on a morning, but you know, once we've got the system up and running, it's quite simple to set up a simple search, and the simple search is already there for me. I built it in, so I just come in on a morning, click the button, and it brings up all the shoulders and arm X-rays done the previous day, and I can sort of scroll and work my way through this. Now by doing this, it sort of gives it access to all the pathways, making sure that we explored everywhere that possible patients were coming in from. Our PAC system here incorporates all the multi-sites, so it was easy to see if patients were coming into another site or and were then passed on. The good thing about also looking at that is that it gives us the patient's identification details. So from that, I was able to find the patient, find where they were being passed on to, whether it be an upper limb clinic or indeed into our virtual fracture system. Obviously, since COVID started, and I'm sure the same at your sites, we've implemented a virtual fracture clinic system where patients are reviewed virtually and then are passed on to the correct pathway. But it just means that I was able to see these patients from a really early stage. In fact, one of the patients that we did actually manage to recruit using this new system, I managed to get that patient on the day of their injury, and it was literally had them seen within 2 hours of them coming in, and got them seen by our on-call consultant, passed on the details to our upper limb team, and we brought that patient in and went through everything. Because of that early identification, we negated the fact of the treatment problems that we seem to get with a lot of other people that do come through. That patient, again, it was given the options, they were given the time. It's a really easy way to streamline it. Like I've said, it does take a little bit of work and it does take a little bit of effort to get there. But I think the work that we've done into this has started to show dividends with the patients that we've recruited, and also with the way that we're actually screening patients. Because we can identify them, we can easily see the patients who are coming in as 65 and above, and if anybody who I think is a potential PROFHER-2, I can bring them up to the team. I've created just a little team email, and if I do find any patients that could be possible, I'll send them on. Now, it is quite hard sometimes to see whether it is a 3 or 4 part eligible patient that needs to be included. So sometimes it's just being able to create that email, to send it out, say, look, I've got this X-ray, here's the patient's number, can you have a look at it, can you confirm it? A lot of the time that we do find them, but a lot of the time it isn't suitable. However, what that does is it negates the time that it takes to try and hunt down, to try and find somebody to say, look, is this patient suitable? If they are suitable, we can bring them into clinic and we can speak to the virtual consultant, if you will, who's on call that day. And I can go, for example, I attend the virtual meetings that usually held around lunchtime as well now. And I can bring these up to the clinicians there and say, I've already flagged this patient up. Are you happy for me to get them seen by an upper limb? And 9 times out of 10, it's a yes to get these patients seen. Once I've got that go ahead, again, through that early identification, I can contact the patient, I can discuss with them what's going on, introduce the idea of the trial at a really, really early stage. And if they've got access to electronic systems, emails, things like that, I can actually pass on to them the patient information leaflet. So it gives them something to think about, that the trial is there, the options are there, and it's something that we want to engage them in the process. It shouldn't be what we've seen when I've talked to a lot of our patients, where they've just come in and thought the expectation is that the patient would come in, the surgeon would tell them exactly what's needed to be done, that would be done, and they would walk out the door a happy person. It's been really important, especially the past couple of patients that I've recruited, that I've been able to spend the time with them, going through everything, how the trial works, what we do as research nurses, how we can provide additional support to them. So again, this streamline seems to be working dividends to us, and it is pulling people on board who we would potentially have missed. Like I've said, the considerations are that it does take a little bit of time from my side, and particularly on a Monday morning, when obviously I have to go through from the close of business Friday up until first thing on a Monday morning. But again, that little bit of effort has paid off, and that's where we're finding the majority of patients. Again, those patients may have been missed on a weekend, but now, if nothing else, we're getting them on a screening log. It's great that sometimes, even if I don't have a patient who, when I look at the x-ray, I can sort of know that it's not really a 3 or 4 part, but just to keep the ball rolling, just to keep the foresight within the team, I'll pass that on and say, I found these 2 x-rays, can you have a look, just see what you think? And again, it gives me the ability to create a complete screening log of every patient that comes through that potentially could have been eligible. Like I say, a lot of the times they're not, but it's just the fact that we're creating such a stone, if you will, and a wheel of how many patients we can actually see. Getting people on board has been difficult again with our team. Myself and my colleague Juliet here, we attend our Reg introduction scheme, and we do teaching, and we try to get them involved at an early stage. We talk about getting them onto API systems and getting dedicated research teams. Again, a little bit of work goes a long way, and we find that once we can get those regs on board, get their GCP, get their certificates and the CVs up and running, get them on the delegation log, we're encouraging them to take part. And that's something that we find, again, massively helps us when we're not available, because we aren't available all the time 24/7. We do have a number of studies that I'm looking after, and the same with my colleague. So again, it's just as many eyes on the ground as that we can get. And again, it's that commitment. Now that the PI and our upper limb team have seen the commitment that we are doing, they seem to be a lot more engaged with us. And maybe sometimes a lot of the patients that we've seen before, where I look at the treatment outcome, where sometimes it would be that the majority of our patients unfortunately end up for non-operative reasons, for everything from the patients are not fit for surgery through to a patient's choice. Now we've got everybody on board that we don't have that sort of problem with equipoise. We're able to take that to the patient and give that patient the option to say, look, these are the options that are available. And it seems to be that we're more engaging those patients at that early doors. Next slide, please, Dan. So the benefits is that we're seeing early patient contact and trial information is being passed on to them. Like I've said, we're able to see patients typically from within a 12-hour period of them coming in. We're able to capture all of the patients coming in, whether they be eligible or not, unfortunately, when we do the screening process. But the whole point of the system is that we're able to identify them at such an early point. We're then able to verify inclusion and exclusion and plan ahead of that clinical visit. By planning ahead and doing that early contact, we found that when these patients come into clinics, and I'm pretty sure it's the same at the sites that you are, that obviously patients and clinics tend to overrun. So if we know that we've got a patient coming in, what usually happens is our surgeon will go in, introduce himself, introduce them to the trial and hand it over to me. And then I can take as much time as I need to with the patient, which frees up the clinician to see the next patients on their list. So again, it just minimizes the time that's needed, rather than say, oh, I've got a patient, can you come down? I may not be available because I'm elsewhere, but it just helps with patient flow. And we've seen that that's worked off with especially our limited space in our trauma outpatients department. And again, like we've been pointing out, we've had this enhanced screening method as we really started it in December, and we started to push through, and I did a retrospective review of what we could have potentially missed, and paid off dividends. We recruited 2 patients in December, and we identified 3 patients in January that actually we would have potentially missed had we not had this enhanced screening procedures in place. Unfortunately, the patients didn't come into the trial for various reasons, but it's the fact that we were able to engage at such an early stage and make that decision that I think that we're able to move that patient's journey, that healing process, a lot further forward. And that's it from me. Unless anybody's got any questions, then I'll say thank you for my time.